Thanks for coming. You know, people ask for just kind of a brief summary. What are seizures? What's epilepsy? And people, as you know, the people we support, our employers, people with IDD, have a much higher frequency of having some form of seizure disorder than the general population. So I'm just going to walk us through some of the basic definitions. We have another seminar where we're going to talk about unusual seizures that are often mistaken for behavior or psychiatric symptoms. That's a little bit of a different discussion, but today we're just going to talk for a few minutes about typical seizures, how they're classified and described, and what is this VNS thing, the vagus nerve stimulator. I'll mention a couple of words about that as well. So, seizures, VNS. What is epilepsy? It's a generic term. Some people put a lot of emotional feeling on this term, like seizure disorder is a better thing than epilepsy. And that's because, unfortunately, many, many years ago, people used to try and say that there was like an epileptic personality, or epileptics were somehow a disagreeable population of people. It was just old style prejudice and bigotry applied to people who happened to have this one neurological condition. Also, not that many years ago, we didn't have anything to help manage seizures. So I know maybe many of you that have seen a seizure for the first time, it's a little startling. It's not an everyday sort of a thing necessarily. However, as people get comfortable with understanding that seizure disorders or epilepsy, or whatever terms the individual person prefers, we can understand it and help people through it, help them get the best life possible. A seizure is a disturbance in the electrical impulses of the brain. In other seminars, we've talked a lot about how all of neurophysiology is chemical, electrical, structural, or fuel line. And epilepsy, per se, is the electrical type of seizure, where the circuitry in the brain, all those electrical impulses, are somehow over-concentrated in a particular area in a way that activates that brain, part of the brain, in ways that are not under the person's preferred control. So what does that mean? It's a sudden overload, and this affects the brain's functions. Overfunction, underfunction. There are 20 different types of seizures. 2.5 million people, 40 million worldwide, have some form of diagnosed seizure disorder. And there's a great amount of literature that suggests that seizures may be under-recognized simply because people aren't really looking for the more unusual or more subtle types of seizure disorders. 1 in every 10 people in this country will have a seizure at some point in their life. That does not necessarily mean the person has a seizure disorder or epilepsy. For about 70% of people, the cause of the seizure is unknown, or the cause of the seizure disorder is unknown. People who have a single seizure, often the cause is known. Electrolyte disturbance, their sodium drops too low, or they have a terribly high fever, or some other obvious what we call proximate cause. However, for people that have recurrent seizures, about 70% of the time, no one knows why. Heredity is a big factor. If anybody has a form of seizure disorder in the family, every one of their descendants is more likely to develop or to experience a seizure disorder of some type. Brain tumors and strokes can trigger seizures. Poisoning can trigger seizures. And this can include anywhere from lead intoxication, alcohol intoxication. and many, many different types of stimulant medicines, as well as withdrawal. People withdrawing from opiates and alcohol particularly have a vulnerability to develop seizures. And if there's any injury to the person's brain when they're in development, that can produce a scar that can be a focus where a seizure disorder may develop. So, what are the different types of seizures? Simple partial seizures are often the least recognized, but they're very interesting information in terms of how it might influence a person's functioning. There's partial complex seizures, there's generalized seizures where the entire brain is involved and may include the entire body, but not necessarily. Focal onset seizures are where a person starts the seizure with a simple type of a seizure, but it may generalize to involve the person's entire brain, or it may spread to only involve a few other parts of the brain. Focal onset general seizures, focal onset partial complex seizures. And generalized onset, those are seizures where the entire brain is affected immediately. So what are we talking in terms of simple partial seizures? And I show one neuron connecting with another neuron in a very artistic CG generated kind of a way. Simple partial seizures can affect any function of the person's body except consciousness. And this is fascinating because certain simple partial seizures will appear to be completely different phenomena. And I'll show you a picture in a minute. The motor simple partial seizures are the most recognizable. A person has a tiny little focus in the motor strip and their seizure is this, and then it stops. That's could be a simple partial seizure that involves a little nucleus in the motor strip affecting the arm that's connected up to that neuron. Autonomic simple partial seizures are quite difficult to detect. These are ones where a person may have sudden episodes along a seizure pattern of sweating, vomiting, breathing issues, and other kinds of autonomic function. Autonomic means all that unconscious body function. Limbic seizures are a simple seizure that involves the mood and anxiety center of the brain. That can all be lit up in a seizure where the person is fully conscious and they look for all the world like they're having a very unusual type of panic attack. However, the treatment is completely different than the treatment for panic disorder per se. Amygdaloid seizures are seizures that involve just that little, what's the technical term, doodad, in the middle of the brain where rage, fear, recklessness, and anxiety live. And people will have explosive episodes of anger that literally come out of nowhere and may have this caused by an amygdaloid seizure. Very, very difficult to detect. This particular picture is from a very old classic textbook that is one of my favorites. It's Frank Netter, wonderful physician artist, really knew how to illustrate things. Simple partial seizures, you see a focal motor seizure there in the upper right. You'll see people with just not very dramatic, but completely involuntary grimacing types of gestures or other movements. Autonomic things like we talked about, sweating, flushing, nausea, peculiar sensations, rising sensations. Also, people can have simple seizures, simple partial seizures involving the visual cortex. So they will have visual hallucinations because the seizure has lit up that part of the visual cortex. And of course, as you probably know, antipsychotic medications make this type of seizure worse. So people may get into a little bit of a cycle of, well, they're hallucinating, we give the person antipsychotic medication, they get worse, so we probably need to bump up the antipsychotic medication. You can see the spiral that leads to. In the seminar on unusual seizures, we will talk about when to suspect a particularly unusual seizure, and hopefully avoid some of that kind of spiral that, of course, can happen from time to time. And somatosensory simple seizures, where a person will suddenly have a part of their body that feels strange or tingly or painful. And some people suggest this may be part of the origin for some people of complex regional pain syndromes, or reflex sympathetic dystrophy is the older name for that. So these are seizures where there's basically one focus and it does not alter a person's level of consciousness or alertness, their ability to perceive what's around them. What are partial complex seizures? And these are probably some of the most controversial. Being a neuropsychiatrist with a specialty in the people I specialize in, I've probably seen more partial complex seizures than a fair number of neurologists who never get to see particularly specialized populations. One of the things is that you'll hear sort of around and about all these supposed rules about seizures. They're always short, they're always the same. People don't have memory. Well, in fact, the rules really don't hold up to clinical reality. We'll talk a little bit about that now and again in the seminar on unusual seizures. Sometimes people who are having partial complex seizures can shorten up the seizure with sensory input, basically flooding their brain with something else. So I've known, for example, some people that were able to shorten a seizure by pouring cold water on themselves, which sounds miserable, but the person figured this out for herself. Some people will find certain loud types of music or noise can shorten up a seizure. Some people find that switching off the lights and getting that kind of stimulation removed can help shorten a seizure. And for some people, none of that stuff works at all. Since more than one part of the brain is involved, there can be a lot of accompanying symptoms that are not necessarily making sense in terms of all the way they all go together. People can have mood symptoms, motor symptoms. There's a phenomenon, for example, called a Curatorian seizure, where a person will have howling and crying, but in fact doesn't feel sad in any way. That's sort of the paradox of partial complex seizures. What the person is doing and expressing may not, in fact, really reflect what they're feeling or thinking. Usually, partial complex seizures are fairly short, a few minutes, and usually they follow the same pattern every time, but not always. If the person has any memory for the episode, and they sometimes do, it's usually kind of spotty. A little bit like a strobe light shining up their memory. And many people with this type of epilepsy who do have some limited awareness and memory describe this dreadful feeling of watching themselves do things and being powerless to stop it. And what are some of the other examples? These are more simple partial complex seizures where people will have alteration in consciousness. They may have complex auditory and visual hallucinations. They may have olfactory hallucinations. They may start unusual physical gesturing, or one example I've seen frequently is people that can't quite get all the way through a familiar activity. They can get the spoon in the cereal, they can get it up about this high, and then it just kind of stops. And they just keep kind of doing this near miss version of familiar activities. There's many different types of partial complex seizures, as many types as there are parts of the brain and function. Generalized seizures involve the entire brain. There's a loss of consciousness, and the person has no memory for the seizure. There's two types of generalized seizures that I think we're all probably familiar with. One is called generalized absence seizures, where basically the person's brain shuts off for a second or a fraction of a second and then flips back on. This is the type of seizure that a person can be experiencing for years before anybody catches on. They often look like they're being inattentive. They often get a preliminary diagnosis of ADHD when in fact their interruption of attention is a seizure, not the more chemical aspects of ADHD. There is also what's called a status absence seizure pattern that occurs more often in elderly people, where a person will have absence seizure over and over again, and it will look to all the world like they've developed a severe dementia, but it's treatable. People wake right up when it's recognized and treated. Generalized tonic-clonic seizures are the ones that I think most people think about when they think about epilepsy. The symmetrical jerking movements, the tongue-biting incontinence, need to turn the person on their side, all the sort of usual seizure precautions. Obviously, a lot of people we know have that type of seizure, and there's many treatments. It's pretty straightforward. The other kind of generalized seizure, it's very unusual, important to know about though, is called an atonic seizure or a drop seizure, where a person loses tone, drops to the floor, and they get no warning. For generalized tonic-clonic seizures, where people have the movements and so forth, people often have a little bit of warning, but not always. And it's felt that the new and emerging science of PET-assisted therapy for epilepsy really focuses on recognizing drop seizures before they happen to try and minimize the injuries involved. Obviously, we want to optimize anti-epileptic medication treatment, but that is not always an instantaneous process, is it? But seizure dogs are an extraordinary benefit to an awful lot of people with serious and complicated epilepsies. Some seizures give a little warning ahead of time. Like I mentioned before, people will have an aura. And an aura can be almost anything. It can be a feeling of nausea. People will describe a sensation of that their abdomen is rising. People will have visual distortions. They'll get unusual odors often, or tastes in the mouth. The metal taste in the mouth is a classic aura for various types of epilepsy. Some people will report that they'll start to hear the same piece of music over and over again, not one they care about, but one that lets them know a seizure's coming. Some people will have olfactory auras of nasty smells or even benign smells. One man, I mentioned him in another seminar, his seizure aura was the aroma of his mother's kitchen, bread baking and cinnamon. Not a bad way to get warned, right? That you ought to sit down and rest a minute. There's focal onset with secondary generalization. So a person starts with a partial seizure, which then spreads over the entire brain. They may have a little bit of memory for the first onset part, but they won't remember anything subsequently. Focal onset preceding partial complex, memory can be spotty, as we talked about before. Partial complex onset is one of the ones that can be very vexing in terms of diagnosis for a couple of reasons. First, having more than one part of the brain light up at the same time is a very unusual phenomenon. And number two, most of the parts of the brain that light up with partial complex seizures cannot be detected through surface EEGs. So a person can be in the middle of having a partial complex seizure, and the EEG, the typical EEG with surface leads, won't show anything. And they may end up not getting properly diagnosed. And then generalized onset for the absence seizures, the drop seizures, the generalized tonic-clonic seizures, sometimes those start fully developed without any prodrome or warning. What else can look exactly like an electrical or an epileptic seizure? Well, the most common other thing that looks exactly like an epileptic seizure is a non-epileptic seizure. And some people mistakenly call these fake seizures or pseudo seizures. That's a mistake. Non-epileptic seizures are just as involuntary as epileptic seizures, but the origin is chemical, psychiatric, post-traumatic panic. So saying this isn't a real seizure is not quite accurate. And it certainly doesn't give you the information you need to help the person. Non-epileptic seizures also require extremely thorough assessment and treatment, and they often coexist in the same person. Fake seizures. Now, non-epileptic seizures, typically the person is not deliberately pretending to have a seizure. They are a catastrophic neuropsychiatric event, but the origins are chemical instead of electrical. However, a person who fakes seizures on purpose, that's a slightly different category. And just to make things interesting, people who have well-documented electrically based epileptic seizures almost all fake a seizure from time to time. So that makes things just a little bit complicated, and also makes you wonder about a person's life. It's like, wow, why is this more interesting than the person's life? Pretending to have a seizure. Yikes. Thought blocking, which is a symptom of severe schizophrenia, can be easily mistaken for absence seizure, generalized absence seizure. Basically, a person with schizophrenia can be quite vapor locked from overrunning of the gating, sensory gating. When we talk about schizophrenia, we'll talk about that in more detail. And they simply cannot take in anything more. That looks for all the world like a type of a seizure, but it's chemical in origin, chemical and structural. Complex migraine, a lot of overlap with seizures, but the origin is not electrical, it's fuel line. And otherwise, it can be very hard to tease those apart because they not infrequently coexist. Transient ischemic attacks and strokes can trigger all kinds of seizures, seizure activity, which is why, in the opinion of many seizure experts, every person who has their first or new onset of seizures should be thoroughly evaluated. The old thinking was, you have a seizure, it's probably nothing, don't worry about it. Unfortunately, that kind of response will miss a lot of really important stuff, like electrolyte disturbances, masses, strokes, transient ischemic attacks, and other triggers, even if it is just the one seizure. Heart rhythm disturbances can simulate seizures, particularly drop seizures. If a person has, for example, long pauses or ventricular tachycardia or even atrial fibrillation, that may lead to some either movements or loss of tone that can be easily thought to be seizure activity, but it's fuel line. And extreme pain. Extreme pain can cause convulsions that look for all the world like seizures, electrical seizures. So I want to just say a couple words because I get a lot of questions about what's a vagus nerve stimulator. Well, it's a gadget that is used as add-on treatment for both seizures and depression. The mechanism of action, the why it works, is not totally clear, which can make us all a little bit uncomfortable. It's thought that the electrical waveform of the big vagus nerve disrupts abnormal electrical waveforms in the brain in a way that reduces the likelihood of those abnormal electrical waveforms blossoming into seizures. It also is thought to stimulate sluggish brain activity, which is thought to be part of the underpinning of depression. That's what they're thinking, and we've all certainly known people that got a really good result when they had a vagus nerve stimulator. They're not as popular for depression as I think they hope to be, but I'm still seeing some pretty darn good results for a lot of people with the more complicated forms of seizures. And this is just a schematic of what it does. The gadget's implanted, of course, in the chest and then attached to the vagus nerve, going north and south. Now, people with a vagus nerve stimulator are also issued a magnet, a thing in their hand. That is for extra pulses. If the person looks like they're headed for a seizure, the magnet will trigger an extra pulse of the vagus nerve stimulator that will hopefully prevent the seizure. The magnet is swiped across here where the device is implanted. And the reason I mention that is that we've had a few employers in the hospital where people that didn't really know how to use the device kept swiping the magnet across the person's head. That's not how it works. It needs to be swiped across the device to trigger the pulse to maybe prevent the seizure. People who are conscious will know usually that the VNS is working because each time it pulses, their voice changes a little bit. And it's not a very, it's not painful or anything. People get used to it, but it's a good sort of a clinical way to know that the thing's in place. So what are some risk factors for seizures? Who is more likely to develop some form of epilepsy? Genetics, as we mentioned before, is a big deal. Head injury at any time in a person's life can be associated with the increased onset of seizures any time in a person's life. And that's because the brain is continuously going through healing and remodeling and scar formation. So the head injury a person might have had when they're 8 may not turn into a seizure-generating scar until they're 20 or something of that nature. Certain medicines increase the risk of seizures, tricyclic antidepressants, some antihistamines, some antipsychotic medications, and bupropion, also called Wellbutrin. Certain vascular anomalies can contribute to the onset of fuel line disruptions and produce seizures. Brain tumors, medications that lower sodium, fever, total body infections like sepsis, and infections in the brain can all alter electrical activity to the point where it can trigger seizures. And of course, cardiac rhythms. We have a couple of misconceptions that are out there. that we should correct, and remember that we may need to correct in others. The most important one is this idea that an EEG, the thing where they put the leads all over the person's head and wait a while, and maybe they have them hyperventilate or fall asleep or any of the above. There's this idea out there that can tell you whether or not a person has epilepsy. That's wrong. The purpose of an EEG is to maybe tell you where the seizure is. It can't tell you whether or not a person is having a seizure. I pinned down a number of epilepsy superstars, and I consider them superstars when they do good work for complicated patients, who say that if a person's story is convincing, they should receive a trial of treatment no matter what the EEG says. Research shows that even very skilled and experienced epilepsy specialists can't tell a non-epileptic seizure from an electrical seizure just by looking. And that's terribly important, isn't it? We need to do the work of figuring it out because the treatments are so widely different, both important, widely different. Non-epileptic seizures are not the same as fake seizures. I mentioned that before. Need to reiterate that in case people mix up their terminology. And nighttime seizures are just as deadly as daytime seizures and should be treated. I mention this because from time to time I'll hear, well, he's only having seizures at night, so we're not treating him. In fact, failure to treat seizures, especially nighttime seizures, massively increases the risk of death and also contributes to progressive, preventable loss of function and health. For more good first-person information and plain language information, I direct you to the Epilepsy Foundation. One of the things I really like about the Epilepsy Foundation is that they have a lot of stuff written by people with epilepsy about what it's like, how hard it was to get a proper diagnosis, what medicines mean to them, and so on. So thank you very much for attending this speed overview of seizure disorders.